prevertebral soft tissue is important to see this in your checklist when you are going to report, especially in rapid reporting, that you check the soft tissue in front of the vertebrae. Yes, so thickened retropharyngeal soft tissue, and the most important differential diagnosis will be retropharyngeal cellulitis or abscess. So you measure, it shouldn't exceed like 2 millimeter in level of C6 and 2 centimeter in level of C6 and around 8 millimeter in level of C2. So you cannot exceed this measurement. Let me show you the CT. If you go to see the CT, you will find that there is soft tissue with collection, and maybe in the post contrast you can find the collection here. Yes, so there is abscess. Okay, this is a case I think is interesting also because is easy one, but maybe they like it in some exams. What do you think about this? CT brain, non-contrast plain CT, yes. There is some air loculi. So what do you think? What do you think about the source of this air loculi? Dr. Muhammad, yes. Yes, so this is what is called air embolism. Yeah, it's not very common to be honest, but just think about it. One of the important that it can be air embolism, iatrogenic, yes, iatrogenic. Let's see this case. This is a plain chest X-ray, as you see. It's not easy one, but when you go to the check the region of importance, like the costophrenic angles on both sides, you can see the left hemidiaphragm is upward elevated, right? And the most important, Dr. Nakhil, yes, that you can check the left hilum. So the left hilum is bulky. So there is a left hilar lesion or obliteration. And through this left hilar shadow, you can see that there is some like tram obestes, tram track obestes here. Just you can think about differential diagnosis. Sure that you will put like the malignant reason, one of the best differential diagnosis. But if it is not malignant, can you give any other differential diagnosis? When you see something in the upper lobe, try to think about, especially with this tram track appearance, think about bronchiectasis. Sure, it will be difficult in the X-ray, but if you go to the CT, you can get it more easier with this appearance. And yes, it make again obliteration of the left hilum. So what do you think about this appearance? Yeah, it is like, I agree with you, it's make like what is called bronchocele. So 1, 2, 3 at least. There is obstruction here. So this is what is called finger in glove appearance, branching lesion. superior segment of left lower lobe. So what your final diagnosis will be? Yes, Dr. Aditi, yes, allergic bronchopulmonary aspergillosis. Yes. So this is the bronchoseals, which give finger in glove appearance. And you can think about allergic bronchopulmonary aspergillosis. Yes. And this is another patient. Today, I try to focus in the chest. This plain chest radiograph. So what do you think in the left side? What is in the right side? Is interesting case. There is unstable connection today, sorry. Again, so it's okay now. So this patient, as you see, he have this left lung opacity. And maybe you can see that there is maybe associated thickening, interstitial thickening here, if you could note it. So if there is left lung midzonal paramediastinal lesion and there is thickening here, so what do you think about this? Okay, if I told you that this patient have previous history of breast cancer, is it easy? It will be easy for you. I think it will be easy, right? Yes, so maybe it will be like a breast implant. And if you go to the CT, maybe I can try to, yeah, you will find that there is bilateral breast implant. But the most important, rather than the implant, this appearance, which is typical for, now I will go to the CT X-ray again. Yes, lymphangitis carcinomatosis. So it's important to interstitial thickening to be used to see the interstitial thickening, especially with the cancer patient. You should suspect the presence of lymphangitis carcinomatosis. I agree with you that there is right-sided aortic arch. Yes, here. Perfect. Dr. Aditi. This is a variant. And there is also emphysematous changes. Yes, but the most important, as you mentioned, that this patient, he developed right now like lymphangitis carcinomatosis. Also, you can see that there is right-sided aortic arch and right also sided heart, which is dextrocardia. And if you go to check the gastric bubble, you will find the gastric bubble, it is in the right side. So for you, this patient have what is called situs inversus, yeah. So this patient have this, and he have another finding, which is more important. So it was interesting case with situs inversus and lymphangitis carcinomatosis. This patient developed abdominal pain, and when you go to check for the abdominal checklist, which is important to comment in the emergency. Yeah. What is the emergency? It will be here. The air fluid levels and the dilatation of the bowel loops. So there is probably small bowel obstruction. or you can say small bowel dilatation, and search for the obstructive agent. If this is mechanical or ischemic or inflammatory or type of closed loop obstruction or whatever. But at least you can check for the cause. You will go to CT and what do you think about the CT? So there is small bowel obstruction. When I see the small bowel obstruction, the most important approach that you go first to check the mesenteric ischemia. Check first for the superior mesenteric artery and vein, if they are okay or not, and if there is any bowel gangrene, then go check for the liver if there is any portal venous gas, or after that try to check for the other, like if it is inflammatory or there is any mechanical obstruction. Here easily you can see that there is a volvulus. Yes, perfect. Here there is some sort of volvulus of the bowel loop. I am sure that you need to check the rest of reconstructed image, especially the coronal if there is present, but you can see there is possibly there is cecal volvulus here. Yes, in the colon. Yes, right side of the colon you can see the volvulus here. Yes, so there is right upper abdominal bowel loop, and after that happen the small bowel dilatation. So this is what's called cecal volvulus. There will be some discussion about the volvulus. The most important, you should comment it in it, the free intra-abdominal air to exclude there is any perforation. They say also the good thing that you can see the whirl sign as you saw it, and there is also some fluid levels. They mentioned that there is recent laparoscopic, this is the cause of the free abdominal air in this case. Anyway, small bowel obstruction is very frequent in the exams. Any exam you will be, you will find something related to the bowel. Let's see this case, chest, plain radiograph chest. This patient, what is the good differential diagnosis you will put in this patient? So you will mention sure that I will wait for your answer. Yeah. The first differential diagnosis you should put, it will be yeah, I know that's easy. Yeah, it left upper lobe mass. So the best differential diagnosis you will put, it will be lung cancer. In many institutes, they like to order PET CT, but the most important to check if it is resolving pneumonia or not. So that's why he did, after 1 week, another X-ray. So what do you think about this? This proved that it is lung cancer, and he did this X-ray. Yeah, there is probably opacification. As you see here, there is opacification. I can see the opacification, yeah, of the left hemithorax. And there is a shift of mediastinum. Yeah. So this is typical of post-operative changes. Yeah. So this patient, he did operation and he removed this Yeah, he did pneumonectomy. Yeah, and you can see that there is some tracheal deviation here, ipsilateral deviation, and pleural effusion. And there is some exam question about the what is called bronchoblura fistula. So this is the normal to see this post-operative, and this is normal that you see opacification. The abnormal thing that you see increasing air in the X-rays. So if you see like increasing air in the post-operative X-rays, this means that this patient may develop bronchopleural fistula, which is not a good sign. So the good thing that you should make follow-up to this patient to check if you have any abnormality. This patient did again another follow-up after period of time. Yes. So what do you see here? There is nice rib fracture. Perfect. This is a rib fracture. He's the same patient, yeah. And yes, you can see that there is pneumothorax. Perfect. So when you see rib fracture, the important thing to search for any pneumothorax related. Maybe he have any pneumothorax from the rib fracture, and also to check for hematoma or hemo effusion or blunted costophrenic angle or any pleural effusion. So this was interesting case. He have many issues in one side, and he have this what's called post-operative left bronchopleural fistula. At this patient, we mentioned that he did surgery, and after surgery, we see that there is developed air, and this is one of the most important complication after he was like opacified left hemothorax. So if you find like increasing air in short period of time, so this means that this complication is not a good thing. He already have a rib fracture, and he have also like what is more like pneumothorax also, and some effusion, and so all this indicate that this patient have bronchopleural fistula in one of the post-operative complication. Okay. Yes. This another patient, and maybe you can note that there is some cardiomegaly in this patient. There is effusion here, yeah, and there is right lung opacity, lower zone, and hardly, if you can note that there is some air here, and there is like a fluid level in this side. So this could be again type of hydropneumothorax, and like lung, there is lung opacity in this what is called basal pneumothorax, and already the patient he have like CT demonstrate that this is related to atelectasis and thickened pleura. is not easy to detect the basal pneumothorax, but maybe you can suspect, especially with presence of the fluid and the lack of lung markings here. Yes. Anyway, yes, air fluid level, Dr. Amani, perfect. I want to show you some short cases that can help also in the preparation of the exam. So what do you think about this? Is not easy one, but if you try to make tracing for the right paraesophageal line, or at least you can see that there is double density of the right cardiac border. So this is the right cardiac border, but this is another opacity. In the right side, if you remember, either it is something related to the mediastinum, especially if you go to the posterior mediastinum and there is the structure here, which is the esophagus. Yes, esophagus always when it is dilated, it is in the right side. It is not easy one. Yes, Dr. Rahil. So this is what is typical for achalasia. Is not easy one, but you should think about it, especially when you are on the right side. And the heart itself, it doesn't look abnormal. So achalasia, if you want to be sure, you should have contrast barium study. Yes. So this one, this is again rapid reporting case. Is easy one. You check for the acromioclavicular, and if you go to check the glenohumeral articulation, you will find that there is dislocation. Yes, anterior dislocation of the left shoulder. When you see this opacities, usually I go to the approach that I check the heart if there is any cardiomegaly or not, and check for any possible source of, it could be infection. So if there is no, I will think, especially when I find that the patient is portable and bedside, that this could be RDS. Yeah, adult respiratory distress syndrome. They have many views of this ERDS, and also you see the lines and the tubes, you should think about something emergency or in ICU. So one of the good differential to be mentioned, acute respiratory distress syndrome. The most important when you check something like this, to comment first in the lines and the tube if there is any displaced or misplaced tubes or lines. This is typical case of asbestosis. So there is multiple pleural plaques, and there is some lung changes basally. So this is what is called asbestosis. This is again some lung basal changes. If you go to this one, sometimes this one is misinterpreted as pneumothorax, but is not pneumothorax. Yes, it is Infestatus Pulley, And sometimes one of them can rupture and cause pneumothorax. So this is what is called Infestatus Pulley. We see the first case today. It was allergic bronchopulmonary aspergillosis, which was like type of focal bronchiectasis in the left upper lobe. But as you know, that sometimes the bronchiectasis can happen also in the lower lobe. If you focus much and you check the lower lobe, you will find that there is some cystic areas here. And the most important differential diagnosis to mention that it could be cystic bronchiectasis, then the examiner will ask you about the differential diagnosis, especially of the lower lobe bronchiectasis and the causes. The most important areas to check when you are this patient, he come like with fever and he presented with fever, and so you are checking for pneumonia. The review areas including the retrocardiac and the epithesis. Don't forget the region beside the vascular, because usually sometimes they can be interpreted as just increased vascular markings, but this was true opacity. There is consolidative opacity here, and possibly here also retrocardiac. Again, not every veiling it can be just interpreted as vascular markings, but this you can see that there is opacity here, so this could be consolidation. We saw the case today, which was lymphangitis carcinomatosis, and this patient was presented with he have like breast implant. This is maybe a similar case, but in another view. That if you start, you can start with this appearance, which is yeah, it's obvious pneumothorax here. Perfect. And both lungs are invaded by multiple metastases. The good thing here, if this patient in young age group and you find like lung metastasis associated pneumothorax, you will think about osteosarcoma. Perfect. But if he's like adult patient and he in the age of other sources of metastasis, so maybe you can think about either in male lung cancer as in this patient, or in female breast cancer. The good thing here, if you mention this pneumothorax, search for other pneumothorax, and you can see here that there is another pneumothorax. So this one, it was bilateral pneumothorax. Okay. Again, there is lung consolidation, bilateral. We will continue for maybe 10 minutes after disconnected. It will disconnect in less than 1 minute. What do you think about this calcification? Let's start after 1 minute break. So what do you think about this? Calcification, subpharynx. So yeah, it can be liver. So if you find, for example, like calcified cyst in the liver, what do you think about it? It can be hydatid. Perfect, yes. So this one, hydatid cyst. This is another example, maybe more obvious, with calcification in the liver. So you think it is hydatid cyst? Yes, here. You can just put a differential diagnosis, and one of them will be the hydatid cyst. Yes. There is, yeah, cardiomegaly, and you should comment in the tube here. So what do you think? Yeah, there is something related to chest. It can be pleural or chest wall lesion. One of the good differential also to be like a chest wall lesion, like neurogenic tumor or something. But I agree with you, it can be pleural. This one is easy. Yes, displaced clavicle fracture here is easy one. This one is not very easy, but let's try to help you with this. What is important for the exam, to be honest, is very important in the exam. Maybe you can see now. So what do you think about the tubes and lines? There is no endotracheal tube. Yeah, but there is a tube here, which if you check, you can trace it here and it going here up. So this was called the coiling, or that the nasogastric tube, it is not in proper position. So there is coiling in the esophagus, probably. Maybe this one more obvious. Yes. So this one, there is coiling in the esophagus of the nasogastric tube. Nasogastric tube is in the esophagus, which is not good in this patient. Yeah. This patient have distension here. But also he have this, which is consolidation. You have this consolidation in the right upper loop with maybe collapse. If you check here, you can find the line. So what do you think about this line? What do you think about this line? So you have like, yes, Dr. Sobhi, perfect. So this is what is called fold. It is not pneumothorax. Why is not pneumothorax? Because you can still see lung markings here after, and also if you try to trace it completely, you will find that it is interrupted. You cannot trace here at least. So this means that it is not true pneumothorax. This is a skin fold. Perfect. This one is easy one, but they like it in the exams, and is important to check for any lines or tubes. Umbilical. So this is what is called the diaphragmatic hernia in the left side. Can be bugdalic. Okay, Muhammad. Yes, Amani. Perfect. I understand that you write in English. So this is again consolidation in lower loop, and the good thing here that is easy for you to detect this one, right? But is not easy for you to detect this one, and this is one of the reviews area that you should check retrocardiac if there is any retrocardiac opacity. So check clearly and try in the exam to make some zooming and de-zooming and windowing until you get the answer. And also in the practice, I think now it will be easy for you to detect this one, which is consolidation in the left lower loop. And here there is consolidation left upper loop, and here which is consolidation left middle loop, left mid zone. There is no mid loop in the left lung, but there is a lingula. And if you go to the right side, what do you think about the right side here? There is silhouetting opacity along the right side, para retrocardiac. So possibly this one in the right middle loop. So there is a pneumonia in the right middle loop in this patient. Again, you should be used to see the consolidation, especially it is a faint like this. So this one was consolidation in the right middle loop, which is the space beside the heart, silhouetting the right cardiac border. And this one is consolidation in the lower loop. And you can see sometimes it's faint like this one, but you should be used to detect any type of consolidation like this. Sometimes it's easy like this, but sometimes it's difficult like this. Also, this is a type of consolidation, right lower lung loop. And here in the right mid zone, maybe possibly here also. This one is clearly. This one is much clearly. And this one, you should suspect TB. Why? Because there is yes, there is cavitation, yeah. And not just TB, you should put other differential, especially the malignant cavity and fungal. But with the cavitation, TB should be minded, a typical location. Again, consolidation. And let's finish today with this as a last case. We started with allergic bronchopulmonary aspergillosis with type of bronchiectasis, and we finish again with bronchiectasis, which is here type of bronchiectasis, which is more central, and probably there will be a question for you: what is the differential diagnosis of cystic bronchiectasis when it is central type? I wish that you enjoy, and it can be a beneficial or a benefit for you. I could maybe ask you if you can kindly, if you can do the feedback evaluation in the group. I send it already. I will be grateful if you did it. Thank you anyway. Inshallah, we continue this training. We just like studying together. I wish that it can be of any benefit, and it can help you either in the exam or in the normal practice. And inshallah, see you soon. And we mentioned the first of the session, as you know, about RSNA registration and about the European diploma resources. I also wish that you can be benefit for you how to make this registration, and you can get benefit from this conference. Thank you so much, and inshallah see you next week. Assalamu alaikum.